Okay, everyone, if you want to just quieten down. All of these people here are all clinicians who have volunteered to be here today. And I see my lovely Spanish colleague at the back. Juan Carlos, would you like to also come down? Oh, I'm sure we can find a space for you. Thank you so much for being here today. This is Juan Carlos Hernandez Beluda. He's published lots and lots of information on MPNs. He's a transplant expert. He spoke to equal number of doctors who were here yesterday. We've also got here Claire Woodley and Louise Wallace, who are clinical nurse specialists / advanced nurse practitioners. And we've got Sonia from the trials unit to answer questions about trials. We've got Rachel, who works with Naumann in Liverpool, Malika, who works at UCLH, Rebecca, who works in Gloucester and Cheltenham, Andrew, who works in Newcastle, Anna, who works in Cambridge, Alessia, who works in Leeds, Mary Francis, who you've met already, Beth, who you've met already, Chiro, who works in Lincoln, Joanne Ewing, who works in Birmingham, Naumann, you've met already, Professor Vostovsek from the MD Anderson, and also Croatia. Then we've got John Lambert, also from UCH, and Jyoti Nangalia, who described the CALR mutation next to Juan Carlos. So I want to say thank you to all of them for being here today. We have, most of them have got a piece of paper which they're kind of fingering slightly anxiously, I think. We have had some questions coming in online. We can take questions live, but you need to put your hand up and have a microphone handed to you, and we will be passing microphones backwards and forwards, which makes me think, is there just one at that end? There's one here. Okay, perfect. Good. Right. Jyoti, you've got a mouse question. I know you told me you don't do experiments on mice, but would you mind just read out the question and then answer it? And those of you who are online, we have noted your questions, but please do feel free to ask some more.
So the question I've been given is, how do you find mice with high platelet levels to study?
Mice with high platelet levels. It's not a trick question. I think it's a good question.
I have there's this mental image of lots of scientists sort of foraging around, looking for little dormice, sadly. No, I don't study mice, but mice are very useful as an animal model. So the way drugs are often developed is you first develop a drug that you think might have some sort of benefit to reducing platelet counts in something like ET, and then you try it on cells growing in a dish and see how it works, and then you move it into trying it on mouse models. And the way that you generate these mouse models is you don't find them, you make them. So you basically give them the genes that give them the disease. And so there are various mouse models developed by multiple groups, UK, America, France. They have 1 or 2 copies of the JAK2 mutation. So as they grow, you can sort of switch on the JAK2 mutation, and then they develop high platelet counts and high blood counts, and then scientists can give them drugs to see if it controls their counts. And the same is the case for CALR. There are a couple of mouse models of CALR as well. And indeed, last year at the American Society of Hematology, there was the big news there was that a drug company has a CALR antibody, which they've tried in mice, and it works really, really well. It gets rid of the high platelet counts and makes the bone marrow look normal, and so that's now entering human trials this year. So they are a good pre-human trial way of studying the disease.
So don't worry, we don't scurry around trapping mice and testing their blood counts. Okay, lovely. If you've got a question in the room, put your hand up, but I'm going to go along the panel. I'm going to ask Anna Godfrey, yes, who's got a microphone. Could you just read out your question, and then we'll move around the room. Yeah.
Yep. Can you hear me? Yes.
Yep.
So this is a question about polycythemia vera, and I'll just read it out. So it says, after recent blood tests prior to venesection, I was called into the GP surgery and informed I was pre-diabetic, but they were confused that I had not been informed before, as my blood tests previously indicated that I have been pre-diabetic since 2013. Is it possible that my blood results with PV have thrown up a high diabetic result? The surgery had not noticed my PV condition. So I would say, in general, I think in the field of MPNs, we are now much more mindful of other cardiovascular risk factors and how they are managed. I think that perhaps 5 years ago, 10 years ago, we would say to GPs, this is a disorder that increases your vascular risk. Please can you make sure the patient has had their blood pressure and their cholesterol and their blood glucose checked. And we still do that, but I think we're aware that there's a big burden on GPs, and we often perhaps see you more than your GP, or it's sometimes easier to get hold of us. So in our clinics, and I think there will probably be some variation, we're trying to be a bit more proactive about looking for those cardiovascular risk factors and making sure that we tell GPs if we find something, and that we give the GPs some kind of recommendations about what to do with the numbers that we find. Really just because we're trying to be realistic, and we've got to look after you as whole individuals, not just look at your blood counts. So if this happened in my clinic, it would be for two reasons. One is that we're actually now looking at blood tests that we didn't necessarily routinely do before. We just asked them to be done in primary care. And the other thing is, coincidentally, in our laboratory, this pre-diabetic range on a blood test called an HbA1c has only now started to be reported routinely on our laboratory parameters. So we now see this coming out on our laboratory results, which didn't happen even a year ago. So I think there's a few possible reasons, but I think we're trying to get a bit more involved in helping with the monitoring.
Okay, and if you use the app, you can put your cardiovascular parameters and it will remind you, and you can show them to us. Perfect, good. So I think, Derry, you've got a question. Yeah, go ahead.
Hello. Hi,
Hello.
This is my first forum. Thank you so much for everyone coming in on a Saturday. I had a question about the MPL variant. I just got diagnosed with ET with MPL, and I've seen lots about CAL-R and JAK2, and there isn't much information about MPL. Is it because it's new, or is it because it's rare? Thank you.
Andrew McGregor, you've got a microphone. You do diagnostics. Would you like to answer that one?
That is a good question. I think you're absolutely right. There is probably less information about patients with MPL compared to the other mutations because it is less common. So the first mutation that was discovered in MPNs was the JAK2, and then after that the MPL, or MIPL, as we call it, was discovered, and that is normally less than 5% of patients with ET. And then CAL-R was discovered after that, which is a lot more. So you're right, that there's probably not as much information about people with MPL compared to the other groups, just because they are less common. But what we know is that they are managed in a very similar way to the JAK2 counterparts, and they seem to do the same as the JAK2 mutation. So you guys are slightly less common, but that makes you slightly more interesting as well. There you go.
And well done for coming to your first forum. Welcome. And so there's a question over there.
I just had a comment about the previous speaker. I'm newly diagnosed with molecular negative polycythemia vera. Also had cholesterol, which is under control. Also non-alcoholic fatty liver, which is being monitored. When I went to see the practice nurse about a month or so ago for my routine smear and my COVID vaccination, she said that I have to have, because I'm also considered pre-diabetic, an HbA1c, a fasting blood test, because otherwise I don't get an accurate reading. So if some of you have that and are not getting it, that's what they've recommended for me. And then when I got signed off from the lipid clinic, my consultant haematologist said that she would take over the monitoring that the GP might be doing. So when I go for the blood tests, I'll have it all done in one hit, and they'll tell me what I need to do.
Excellent.
So I'm really pleased with that communication that's going on.
Great.
And I can't fault it so far. I got diagnosed in August, and so far,
Perfect.
I'm really tired, but
Have you got a good question for one of my colleagues? Is it a comment?
I don't have a question as such, but I'm just highlighting
Perfect.
the different types of care that you may or may not get. And my hospital supposedly does not have a good reputation locally, but I cannot fault the care that I've been receiving when I've been going there, I have to
Good.
say. Yeah.
That's a great
Thank you.
shout out. Thank you so much. That's great. Anna?
Just to come back to that, I think it's really important to emphasise that different things are done differently in different trusts. So it's probably a really good thing to discuss with your healthcare professional as to who is responsible for looking after my blood pressure, my HbA1c, and so on, so that and actually patients can be really great advocates for saying, I need this done now.
Okay, before we go up here, I'm going to ask Beth. There were quite a few questions about inflammation. They're quite tricky, and you're clever. So. Thanks. I think I kind of went along the row with who wants to answer this question on inflammation. So
they're really difficult questions, some of these.
Yes.
Really interesting and tricky questions, but the one I've got here says, can you talk a little bit more about inflammatory diseases and MPN treatments? Interferons, there's quite a lot of noise about inflammatory responses in general, for example, reactions to flu jabs. So is it important to really test for inflammation before starting treatment or to work out what's going on with an MPN? And I guess a couple of things to talk about. I think there's lots of different types or flavours of inflammation. We know a lot about how what we call chronic inflammation, how that might cause and encourage cancer to develop. But that's very different from types of what we call acute inflammation, which is when it comes and goes very quickly. So these are two different things, and I try and sort of keep them distinct, really. So we think that it's the sort of very low-level, ongoing, permanent inflammation that basically gives an advantage to the MPN cells in the body. It's like a race that's going on. You've got MPN cells and healthy cells. They're racing against each other. When you've got chronic inflammation, the MPN cells start winning the race. And when you don't, then they're equal. But that's quite different from having a bit of inflammation when you've got a cough or a cold or an infection or after you have a vaccine. So those things are safe and they don't worsen your disease. So I think, does that answer the question?
We also had a cardiologist speaking to the doctors that were here yesterday, and he was talking also about the fact that chronic inflammation has a role in heart disease and furring up of the arteries, etc. So I think there's a lot of interest. Thinking there isn't really a very specific test for chronic inflammation either. We can do something called a high sensitivity CRP, but I don't think it's very good. In Spain, do you do any testing for inflammation, Juan Carlos?
No, specifically, no, not at all.
Nothing at all?
We are not that advanced.
I do not believe you. Serge, do you do any inflammation tests at the MD Anderson?
No, we look at you for guidance.
Right, you can answer your question then now. Thank you so much, both of you, again, for being here today.
Maybe I should direct this question to you then.
No.
Right, so the question is a serious one. Concern about the trials. What if I am given a placebo? All right. So why do we need the studies that have a placebo as an option at all? There are three phases, and I'm going to simplify as simple as I can get, right? The three phases of drug development. Phase one is you have a new drug that showed promise in the test tubes or in animals, and it appears to be potentially clinically useful for patients that you want to test that drug in, like in myelofibrosis, for example. And you would pick the dose that would, based on mouse or animal, any type of animal studies, be potentially safe enough to start with. And few patients are given that dose, 3 patients typically. And then if there are no toxicities, you go up 3 patients at a time. So you start with, let's say, 50 milligrams. Then you go to 100, 200, 400, 3 patients at a time. And somebody will, at some point in time, get toxicity. So you identify maximally tolerated dose. You can go higher, it's too toxic. Of course, you look at the efficacy at the same time, and you identify the dose that you think it's good to expand. You add many more patients to that dose. Recommended dose for the phase 2. Phase 2 is testing one dose, usually, in many more patients, like 20, 40. That's a phase 2, not blinded. Everybody gets the drug at the same dose. Let's say 40 patients to make sure that the safety that you have seen at the beginning is true, and that you document the activity of the drug at the same time. In myelofibrosis, does it improve quality of life? Does it shrink the spleen? Does it do something else? Eliminate disease from the bone marrow. You're looking for a clinical benefit in phase 2 and confirming the safety, that it's very safe to give. Then you go to the phase 3. The phase 3 would be occasionally blinded, that's the key, blinded randomized study where there would be a possibility that half of the patients are not given the medication and half are, the one that you are developing. That is not very common these days at all. That was the case when we did not have any medication approved in myelofibrosis at all, 15, 20 years ago. But let's give an example of current placebo-controlled randomized study in myelofibrosis. Ruxolitinib has become a standard practice drug. Everybody gets, when they have symptoms or spleen for myelofibrosis, ruxolitinib as a standard therapy. It's given to improve the symptoms and the spleen. And there are several clinical studies where another agent that is investigational, that is ready for the phase 3, is being combined with the ruxolitinib to enhance the response. And how do you prove that adding a new investigational agent on top of ruxolitinib will provide desirable benefit? Well, you have to randomize the patients. Everybody gets ruxolitinib, 100 patients. 50 will, in a blinded randomized study, receive investigational agent on top of ruxolitinib, and 50% or 50 patients will receive placebo. That's the only way that you will see in a scientifically rigorous way whether the addition of new medication provides clinically relevant benefit for possible approval. Typically, these studies would say, we're going to assess the benefit after 6 months of this randomized period. And then we will unblind the study, and those that were on placebo will be able to receive the investigational agents. So the sole purpose is to prove in the best possible way, and that's the blinded randomized study, placebo-controlled, that the additional medication on top of the standard practice ruxolitinib is worth pursuing as a combination. There is no other way. But at the end, everybody can usually get that investigational agents after about 6 months. And so because it's a blinded randomized study, the physician, even the drug maker, and of course the patient, nobody knows whether there is the pill that you are swallowing usually is the placebo or investigational agents. Nobody really knows. That is revealed much later in the course of the study, once the first 6 months pass, where you have your response or you don't. So it's a mandatory part of the drug development to assure the public in a best possible way that the new drug that is getting approved is worth approval.
Thank you. If it's an emergency, we also unblind people, so
If there is something unusual that happens with the patient on a study, always. Safety is always the paramount, right? If there is something unusual and you need to know whether the patient is on investigational agent or not, that patient will be unblinded.
Great. Fantastic. You've done by far the most studies in MPN, so you were a good person to answer that question. Thank you so much. A question in the room. Yeah.
Yes, and this might be a silly question, so forgive me. In lots of the studies, we see results given with confidence intervals. If I get 2 consecutive blood counts that differ by 5 or 10%, I get quite excited, but are there confidence intervals associated with blood count results?
Malika, do you want to use this microphone? Sorry.
Yeah, that's a very good question, and the simple answer to that is yes. And the variation in blood counts can happen if the same sample is tested on the same machine. The same sample is tested on a different machine. So, for example, your GP blood result and the hospital blood result, or if you are tested today and again tomorrow. And that's why we don't place too much value on single changes. We look for trends. In laboratory practice, this standard deviation is very important. There's also the variation due to reagents and all of that the laboratory pays a lot of attention to. And that's all behind the scenes that we don't notice in clinical practice. So yeah, it's a very important issue.
Okay, I think there's two other questions at the back. Lady in blue, yeah.
Hiya, thank you. Mine's probably a very stupid question about the targeted immunotherapies trials that are going on. Does that interfere with interferon, if you see what I mean? If you're taking interferon, how does that work?
Shall I try that one? Yes. So actually, with the current studies, Beth and I both know about them, don't we? So actually, you couldn't do those studies if you're on interferon because of the effect that interferon has on your immune system, because it might confound or muddy the results. So for the vaccine study, the patients should be on no treatment or can be on a bit of hydroxyurea. There's also some concern about use of ruxolitinib for some of the studies because, as we learned from the COVID pandemic, patients don't respond as well to COVID vaccines, for example, if they're on ruxolitinib. So they're all slightly different, but at the moment, we're not doing those studies in patients who are currently on interferon. It's not a stupid question at all. It's a really good one. And then there's another question a bit further back.
So which group of clinicians need to be prioritised for education around MPNs and why?
Rachel, do you want to do that one?
Do you mean in terms of haematologists or all clinicians? All clinicians. Okay. So I was a little bit alarmed. I saw a junior doctor the other day and a medical student, and actually what concerns me is that haematology is very poorly taught at medical schools, and even just asking about a full blood count sometimes fills me with dread when I hear the answer. So actually I think that in terms of haematology itself, and certainly our surrounding MPNs, we should be doing more for medical students. They should be absolutely very clear on what a normal full blood count looks like and where the which abnormalities are actually relevant enough to actually go on and investigate or ask more questions about, because some of those parameters on the full blood count are not important. And MCHC, forgive me if anybody else loves them, I have been referred, a patient who's had an abnormal mean cell hemoglobin concentration, for example. And so it's important that they concentrate on the parameters that are important and then know what to look for. So then to look for things like MCV and things like that. So in terms of answering your question in terms of the MPNs, I think it starts with the basics, basically. And I think if they know how to recognise polycythemia and they know how to recognise iron deficient polycythemia, that's a good start. If they're looking at thrombocytosis and maybe there's a bit of iron deficiency that's causing that thrombocytosis, that's also helpful. So all clinicians actually should be aware of looking, they should all come through medical school with a good basic knowledge of approaching a full blood count. And then they can ask us when it comes to things like myelofibrosis and everything. A lot of that gets taught in PACES anyway, and in the examinations that we do, as when Adam showed before about MRCP. So a lot of those are taught later on. They put a lot of emphasis on examining a big spleen, for example. So things like that will also come through medical training. But yeah, I think it's starting with the basics, personally, is really the main thing. Is that?
Yeah, thank you very much. I think that's a great answer. I think it's really important. I think none of us who are on this stage would want to be a GP nowadays. Because there are so many different things that our poor general practitioners have to know about. And when it comes to blood cancers, there are more than 35 different types of blood cancers. So it's really difficult for a generalist to really understand the total nuances of these conditions. So as Rachel says, they need to be able to understand how to evaluate the blood test, but then it's up to us as the clinicians who are looking after you to say, this is what we need to do, and to be open to dialogue with your general practitioner, diabetes doctor, cardiologist, etc. But we also encourage patients to be experts themselves and to form a conduit as well. And I think specialist nurses also very, very important role from that perspective. So it wouldn't be uncommon for a GP to have only one MPN patient, if that, in their practice. Quite tricky. I'm going to give Naman the opportunity to ask a question that's online, and then we're going to come over here. Yeah.
So I'm going to give it to my co-chair, to Joe. So the one that's got the most votes online at the moment is what is classed as a high dose of hydroxycarbamide?
This microphone's on. Can you hear me? Yeah, you can hear me now. So yeah, I'm not sure we've got an absolute defining high dose. So there is a maximum dose. Hydroxycarbamide is taken for other conditions other than MPNs. And so the dose of hydroxycarbamide can go to really very high levels for patients who need it to control blood counts for other reasons. I would say in my MPN patients that once a patient's got to around 2 grams a day, so that's 4 500 milligram tablets a day, to me that's getting towards what I would term high levels for an MPN patient, but it's not the maximum dose that you can use. And you can take that up to 3 grams a day. And for the MAGIC study, I think Claire can help with just defining. There is a defining dose that says that you have failed hydroxycarbamide if you are needing above that dose, which I think goes up to...
It's 2.5.
2.5,
yeah.
Wasn't it? Yeah. So once you're there on a daily dose, that's what would be classed as a high dose. But we have to bear in mind that there's a huge variability in terms of what dose of hydroxycarbamide patients need. And so I've got patients who are on perhaps only 3 days a week. They take 1 tablet, so a very, very low level of hydroxycarbamide in terms of numbers, but it's what that patient needs. And what I then do is I titrate the hydroxycarbamide down really to the lowest dose that we can get to whilst the blood counts are still controlled. And so it's that good control of blood counts, I think that's the key thing. So, you know, some patients will be on a higher dose than others. That's not something specifically to worry about that you're needing a high dose. It's that it's being titrated to your blood counts. But yeah, there is a point where hydroxycarbamide, you're failing hydroxycarbamide because the dose has become so high that actually really you'd be probably better switching to something different. So,
great answer. Thank you very much. Shall we come to you?
Dr. Harrington was talking earlier about managing cardiac risk, and so you're treating patients whether they're a low risk or a high risk. So if you've had a thrombotic episode at some point before the age of 60, if you've had that very young and nothing's happened, you know, since that point, is there a point at which you say that the risks of something else happening again are quite low, and then perhaps, you know, instead of having to take lots and lots of drugs, am I making sense? So does the risk diminish over time because nothing else has happened since that first episode?
Juan Carlos, would you feel able to answer that? Did you get the question? Because I think the reason I'm asking you is in Spain, you don't have to resort to an app. You've got this amazing database of patients, and you've done lots of looking at things that trigger thrombosis. You've done lots of work on hydroxycarbamide resistance, etc. So the question was about, do you still need to take drugs over time? If you had a thrombotic event at a young age, does the risk diminish over time?
Yes. Yeah, so do you become a less risky patient or a less high-risk patient as time goes on, and perhaps, you know, nothing else has
And is the question about, does that then mean you might be able to stop a drug?
Yeah, or
Okay.
reduce your dosage, yeah.
Yes, I mean, you have to divide the thrombosis into arterial and venous thrombosis. So I would say if you have had an arterial thrombotic event, you're in the high-risk category, and nobody has the answer whether there is a decreased risk over time if you have controlled for a certain period of time your risk factors. But I would suggest you to keep on with the same medication because you are from the beginning in the high risk category. Concerning the venous thrombotic events, some of them are provoked. For instance, you have a surgery, or you have something that may have, or another drug that may have provoked the venous thrombotic event. In that case, the thing is different. Maybe you need certain medications, for instance, anticoagulant therapy for a few months, and then you can stop this treatment. But that's a different situation. Usually, the most common thrombotic events, which are arterial, they put you into the high-risk category, and usually we don't change the treatment if you are tolerating well, and we say this is lifelong treatment. And I think this is what most people do everywhere.
Also, you have to remember that you have some damage probably to the vessels, so
Exactly.
you've got ongoing risk.
Yeah, I mean, if it's just in a very minor vein, and I know we're not supposed to get into our personal thing. If one was pregnant at the time, so that's not a situation, so that would be a risk factor. But if you're no longer and you're not planning to get pregnant again.
Sometimes these kind of things that are triggered, example being pregnant, example being unwell and in bed, example having COVID, then sometimes, But we're kind of getting into personalised stuff. But for the most part, once you've had an event, you've had an event, unfortunately. But for sometimes we can individualise that a bit. John Lambert, you've got a question in your hand. Did you? I think you have.
I have, yes.
Yeah.
It's a very specific and very interesting question. So the specific question is one's allele burden significant in MF treatment? So I just want to broaden that out just a little bit. So the first thing to say is we don't always measure allele burden. So when we say allele burden, what we're talking about is what proportion of, say, an individual's total JAK2 genes in their body, or certainly in their blood count, are taken up by the mutant versus the normal. Because actually this is a mutation that's developed over time, and it's very unusual for their entire blood count to be taken up by the mutant. Usually people reach a balance, so they've got, let's say, 30% mutant and 70% what we call wild type or non-mutant. And in most people, that'll reach a balance. But actually, often we don't even measure it. With newer tests coming out, so it depends how potentially in your clinic, how your doctor will be measuring the JAK2 level or the calreticulin or the MIPL. But these days, if it's done as part of a panel, we may get a level back, and then you're faced with the kind of question, well, how do we interpret that? And the simple answer is there isn't a really good way to interpret it, because each individual person can have a different mutant level, and that will be their mutant level, or their allele burden, or their VAF, it's sometimes called, VAF. But that doesn't necessarily mean that their disease is different to anyone else who's got a different allele level. So I think that's the first thing to say. We don't always measure it. We often don't measure it sequentially. So I think we sort of wouldn't expect to check it every year or every 2 years or whatever. So even if you do know what it is when you're diagnosed, often that's it. And then talking about treatment, well, we don't really know how that impacts particularly on prognosis or response to treatment. So the simple answer to this specific question is no, we don't really alter our treatment based on the allele level, because we don't know how to interpret it in that context. So we wouldn't, for instance, start someone on ruxolitinib just because they've got if they've got sort of what we might call lower risk disease, so intermediate 1 or low risk disease using a DIPS or DIPS plus score, we wouldn't necessarily start them on, we wouldn't start them on ruxolitinib just because they've got a high mutant level, because we don't know that it benefits them anymore. And we know, for instance, that ruxolitinib works very well for people who don't have a JAK2 mutation anyway. So that's the first thing to say. And secondly, do we look to see response? And the answer is no, we don't. So, if someone's on ruxolitinib or interferon, in some cases for myelofibrosis, do we look to see that the JAK2 level's coming down? No, we don't. We know that in some people on interferon, the level may come down, but we don't really know what that translates to in the longer term. So that's a very long-winded answer to say that actually I don't think we would particularly change treatment, and I don't think it would impact treatment knowing what the level is, and we often don't even check it.
We're really trying to find our way with that. Lady in blue.
This is going back to the inflammation that you were talking about. Have you seen any links with the patients that have long-term COVID, and would that affect any of the results that you're getting back?
Maybe I'll do that one. So long-term, we're really learning about long-term COVID. I mean, so some patients who have long COVID have raised ferritin, so iron markers and inflammation markers, but we haven't really learnt a lot about that. But we do see a lot of thrombosis in patients after they've had COVID, and we're starting to see more vascular risk in other ways. But specifically linking to MPN, I'm not aware of any. Does anybody else Beth?
No, I was just going to add that we didn't see a particular signal that patients with MPNs were more likely to have clots when they had COVID, did we? Which was quite interesting because we thought we might see that, but we didn't.
Yeah, I suppose it's because we're treating to prevent, I don't know, but yeah. Okay, and then I think there's another question. Yes.
Hi, can you hear me okay? Yeah.
Yes.
When Beth was talking about immunological approaches, I might have got this completely wrong, but I think the examples she gave were for the JAK2 mutation, mainly talking about vaccine approaches. And then the examples, I think, of the antibody approaches were, I think, exclusively for CALR. I think is there any particular reason for that, or is it just the research that happens to be going on at the moment is for CALR and it could be extended to JAK2?
I don't know whether Jyoti to talk about CALR, shall I?
You do.
Yeah, okay, great. So yeah, there's a good reason. You're exactly right what you said. So the antibody therapies are exclusively going to work for patients who've got a mutation in calreticulin. They won't work for patients with the JAK2 mutation. And that's because the calreticulin mutation is the only one of those two which is expressed on the surface of the cells, so on the outside, so then the antibodies can see it. The vaccine therapy is done a little bit differently, and actually patients will receive the vaccine that contains a vaccine against both calreticulin and JAK2. So whichever one of those mutations you happen to have, you'll actually get a vaccine that vaccinates you against both. And this is because cells do present tiny fragments of the JAK2 mutation, not enough for an antibody to see, but those cells I was showing that were holding out bits of the protein, that they can actually present little bits of the JAK2 mutation as well. So patients with both the JAK2 and the CALR can go for a vaccine therapy. But to make it slightly more complicated, if you've got a JAK2 mutation, there's a 50% chance that you're of the right blood type or the right immune subtype to be eligible. So that's probably something that will be, unfortunately at the moment it's tested for in screening, but you can sort of test people slightly before screening to see whether they'll...
complicated.
Slightly complicated.
And that blood type thing, that's, again, is that something that's kind of hardwired into whether...
It's part of your genetics. Oh, yeah, it's hard, yeah.
If you're not got the right blood type, it's not going to work.
Not at the moment. Well, we can't test it.
Sorry?
Yeah, we can't test it. We can't test it in you if you don't have that particular type. It doesn't mean to say it wouldn't work. It's just that that's the way the vaccines have been designed at the moment. Lovely. I'm just going to do 2 quick fire questions on the panel because the panel have all got questions that were already submitted. So Mary Francis, you're next to Beth. Your question is, I've forgotten what it is actually. Oh, it's about whether treatments can prevent progression. Yeah.
So it's following from Adam Mead's presentation, and he left. That was good. But it's a good question. Is there any evidence or emerging thinking that starting treatment rather than watch and wait may prevent acceleration of cell population development of blast cells and ultimately fibrosis? Now, sort of to unpick this a wee bit, people have a diagnosis made of essential thrombocythemia or polycythemia vera. And we tell them, because we know that there's about a 10 to 15% chance of developing myelofibrosis over the next 10, 20, 30 years, and that there's a very small but significant chance of developing blast cells or acute leukemia, again, over 20, 30 years, and that's probably only about 3 or 4%. And the question is, which I think is a very good question, we would all like an answer to this, is there anything we could give to prevent those events happening? And if that was the case, then why would you wait? The problem is that at the moment, there's no evidence that the therapies we give actually make a difference to the course of that bit of the course of the disease. When we treat people, what we are doing is trying to reduce the risk of thromboembolic events, of clots. So that's why we divide them into low risk, and that's, we talk about low risk and high risk, but it's actually low risk of thromboembolic events and higher risk of thromboembolic events. And the idea then is that you give treatment depending on the risk group in order to reduce that risk. And that's really what all the treatment is about. It's not a question, unfortunately, we would love a treatment that made the risk of the disease progressing less, but we just don't have that at the moment. Okay. There is an added complication because as we start to treat patients, some of the newer treatments we start to see fall in this JAK2 or burden particularly. And that, from a doctor's point of view, is actually exciting, because if you're reducing the amount of the clone that is the disease, will you actually get to where you want in the ultimate, which is, you know, to eliminate the disease? And then if you could eliminate the disease, hopefully you would reduce the risk. But at the moment, we just don't have that evidence. We do see in some of things like interferon, we see the JAK2 burden going down, but it's not disappearing in most, and we actually don't know, you know, for sure, if you got rid of the clone, would that eliminate the disease? That intellectually you'd think it would, but we don't.
We're working on it.
We're working on it.
We're working on it.
We want treatments that do this, but the current treatments, it would not be justified to give them earlier on that basis.
Okay, if you could pass the microphone to your left to Alessia, who's got a question about bone marrow biopsies, and then we'll cut. I think there's another question in the room. Yeah.
Thank you for this great question. I'll read it out. So the question says, how uniform is bone marrow? Can doctors and patients be confident that a single bone marrow biopsy gives a robust and reliable indication of the condition of bone marrow in general? This becomes more critical as samples are subject to different and more sensitive analysis and used for risk classification and treatment selection. So to answer the first question, how uniform is bone marrow? It is not uniform. It's very, what we call heterogeneous, so very variable and very different. And when we take a bone marrow biopsy, trophine, the core is a very small sample, if you've ever seen it, maybe just 2 centimetres long and about 5 millimetres wide. And that's just a small snapshot of all of your bones. So we need to be confident that we're looking at this and giving a reliable result. So the conventional way that we do this now is that we do special stains on the bone marrow trophine. So we do something called a reticulin stain. And in the World Health Organization classification, we say WHO, there's a guide of how this is rated. So we rate this on a scale of 0, 1, 2, 2 and 3. And it's very important that we give the correct grade of this fibrosis so that in clinic, when you're given the result of your bone marrow biopsy, that this is correct. So in our centre and a lot of centres around the country, this will be looked at by 2 hematopathologists and then discussed in an MDT, a multidisciplinary team meeting, where everybody sits down and agrees with this. And the reason it's really important to get the grade of fibrosis right is because it can affect your diagnosis. So usually grade 0 to 1 would be in ET and PV. As it gets towards grade 1, it might be in the pre-fibrotic stage. And then most importantly, when it's 2 and 3, it would be classed as fibrosis. And that might change the diagnosis.
Perfect. Thank you.
I was just going to mention about Dan Royston. He's doing some really interesting work, which we heard some of the data yesterday. So he's looking at a more objective, using artificial intelligence to measure lots and lots of bone marrow biopsies, to use computer grading, so there is less subjectivity of people grading the bone marrow. And also, you might have noticed in Adam Mead's talk, he was showing pictures of how CT scans might also be able to measure fibrosis in more of a subjective, objective way.
Perfect. Pass the microphone on to Andrew. And while we're doing that, we'll just take one from the floor, which is... Yeah.
Sorry, this might have just been answered in the response before the lady before. So we heard a little bit this morning from Professor Mead about some of the genetic mediators that are involved in sort of poor prognostic outcomes. Are there any specific risk factors for leukemic transformation, post-ET myelofibrosis? And if there isn't, is there any sort of work being done on that?
Maybe I'll take that one, and then Andrew, you can correct me if I've got it wrong. So for leukemic transformation, actually Jyoti did massive amounts of genomic work with them. We showed Jacob's and your work yesterday, and what I think you showed is that age has a strong impact on risk of leukemia, diagnosis, and then there's a smattering of risks according to different genes, isn't there? Do you want to just comment on that? And also, some of the older treatments we gave also impact. Things like smoking also impact. Jyoti, sorry, I should have come to you.
No, you've pretty much answered it. Not much more to add beyond that. So we did look at a couple of thousand patients a few years ago to try and understand whether there are features happening in the patient today that we can look at, be it laboratory or examination in the clinic room, or genetics that we could then use to predict what might happen in the future. And there are a few things that come out. There's some genetic mutations that put people at higher risk. However, those mutations tend to be quite rare. So it's, which is good, but it also means that screening for those mutations isn't necessarily the best way to pick them up. And we don't know whether if we found them early and at small levels, whether they'd always go on to do that. So whilst we know that there are some genetic factors and clinical factors that can predict leukemia, they're not necessarily something that are in mainstream practice at the moment, where perhaps one might be regularly monitoring people every couple of years to see if they emerge. That is something that's ongoing to see, can we take that data and work out whether there is a strategy that would work clinically. I think also just generally quite advanced disease, where people have very large clones with lots of mutations, can also increase the risk of leukemia. But to answer your question, is there anything that we can do right now to reduce the risk? As Mary Frances has already said, many of the therapies that we use are aimed at reducing the risk of a blood clot rather than disease evolution. There are some older therapies, or therapies that perhaps we don't use as much, because we think they have a risk of leukemic transformation. So it does feed into therapy, but more in terms of avoiding risk than reducing the natural history of a condition.
Perfect. So it is nearly time to go to breakout, but I haven't given Ciro Rinaldi, Andrew McGregor or Rebecca the opportunity to answer a question. So do you want to just quickly read out your question? And also these are ones that people have asked. So Andrew, do you want to start? Then we'll do Rebecca and then we'll do Ciro. And if there's a burning one in the room, but otherwise I'm going to give you less time for your breakout groups. Andrew.
How do we keep up to date with progress and results from all the immunotherapy trials? So I think coming here is one way. A lot of us will do evening forums throughout the year online, so keep an eye out for the programme for next year. That could be potentially a topic. And for us, it's all relatively new for all of us as well, because this is all brand new information. So we'll all be attending conferences and update days as well, so we can educate all of you guys.
Yep, thank you very much. And we're planning to do, if you pass it to Rebecca, we are planning to do a kind of talk about immunotherapies webinar. And we'll do a post-ASH webinar as well, probably. Rebecca?
My question is, when will ruxolitinib be made available to all myelofibrosis patients, not just intermediate 2 and high risk, or will momelotinib replace Rux as a first-line treatment? At the moment in the UK, in England, we are bound by the NICE guidance, which only allows us to give ruxolitinib to intermediate 2 and high risk myelofibrosis, which is based on they do it on something called a QALY, which is a quality adjusted life years, and they didn't feel that it would benefit intermediate 1. I have actually spoken to the company saying, why can't we give it to intermediate 1? Because there is some evidence that the earlier it's given, the better the results, but the company is not planning to put a submission to NICE for intermediate 1. They've got the PV through, and the momelotinib company at the moment, they're just preparing their submission.
I suspect, but I don't know, that they may improve. They may include intermediate 1. So that's where we are at the moment, but it is different in Scotland.
Perfect. If you could pass the microphone along to Chiro. What I would say is there are so many different prognostic scores for myelofibrosis. Generally, Rebecca wouldn't say this, but I would. If I really think a patient really needs ruxolitinib, I probably keep trying a different prognostic score till I make them intermediate 2. Don't tell anybody outside the room I said that. Chiro.
So I had 2 questions, but I'm going to do the second one because Mary Frances probably covered part of that. Why does symptom load not correlate to blood counts? That's a very good question. So I think to answer the question, I think the complexity of the MPN clone, I think, is not just about the abnormalities in the blood count. So we can treat with some of the medication that effect. So I would say increasing platelets, increasing red cells, increasing white count is an effect, or one of the effects of what that clone is doing in the bone marrow. But then at the same time, those cells are producing stormocytokines that perhaps link with that particular type of chronic inflammation that we've been talking about, where not many drugs act specifically on it. So we know ruxolitinib is very good at that, so it does control the symptoms, and some other drugs do. But not many drugs have the same complex effect on the inflammatory picture, which is why you can have a discrepancy. So you have a very good effect on one of the complications, but not the other.
And that's why it's really important to track your symptoms and talk to us about them. Anyway, I want to say thank you very, very much to all my colleagues. Thank you all for asking questions.